Hello, and welcome to an overview of the Patient Protection and Affordable Care Act. And in this lecture, what we're going to do is kind of give you the basic orientation to the key components of the Affordable Care Act, also known as Obamacare. This act is now 5 years old. It was passed on March 23rd, 2010, when it was signed into law by President Obama. Most of the provisions of the law went into effect on January 1st of 2014. What we've seen is that the law has been challenged consistently in the courts, including 2 Supreme Court challenges. Ultimately, both of those Supreme Court challenges, which questioned the constitutionality of this law, both failed, both on June 28, 2012, when the legality of the state health insurance exchanges and the federal health insurance exchange was challenged, as well as just this past summer when the Supreme Court ruled that in fact it was constitutional for the federal government to provide health insurance subsidies to individuals who had bought plans through health insurance exchanges. So what we've seen is this law has been very much politically contentious. It has had a very rocky implementation in many places, but what we're going to talk about in this lecture is why the implementation of the Affordable Care Act was so essential, what its key provisions are, and what some future trends suggest will happen in the future of the U.S. healthcare system. Now, what we know is that the goals of the Patient Protection and Affordable Care Act, are also known as Obamacare. They really had 3 goals when this law was being designed. The first of which was to increase the number of people who have health insurance in the United States. Before the Affordable Care Act was passed, 45 million Americans did not have access to health insurance. Another big piece of this was the affordability of healthcare in the United States. Increasingly, people were not able to afford health insurance premiums or to be able to purchase healthcare even if they had insurance. And so there were significant increases in the amount also in the last 25 years of how much the United States spends on healthcare. We spend more than any other industrialized nation, and we have poorer outcomes than our other industrialized peers. And so the third part of the Affordable Care Act really has been focused on improving the quality of healthcare that's being provided in the United States and try to rein in those costs and expenditures. And so the first 2 goals were really focused on healthcare consumers, trying to ensure that people could actually access the healthcare system by having health insurance and making the access that people do gain more affordable overall. Now, what are the major components of this law and why are they so critical? So one of the concepts you hear about a lot when we talk about the Affordable Care Act is Gruber's 3-legged stool. Now, Gruber is a professor at Harvard who was a major advocate for the Affordable Care Act and has been one of the primary analysts of its implementation. And what Gruber says is that there are really 3 key components to the Affordable Care Act, all of which are essential and depend on one another. In order for this health reform to be successful, Gruber says that the individual mandate, the requirement for all people in the United States, must exist, because otherwise, without that individual mandate, people could choose not to buy health insurance. And when that happens, usually it's the people who don't have health insurance, who are the sickest, who then don't participate. And so what that ensures is that actually what we see is that if we allow certain people to self-select out of the health insurance pool, we typically see what we call a death spiral, which is the idea that, of course, the sickest people will want to participate in health insurance because they need access to health care and they need help with those medical expenditures. But if only the sickest people sign up for health care, what will happen is, of course, that health insurance premiums will have to go out because health insurance companies are spending more on those individuals. And so over time, health insurance will ultimately become unaffordable. And so by all people being required to participate, healthy young people, middle-aged people with families, older people with multiple chronic conditions, everyone in the United States, it balances that risk out. The other key component of the Affordable Care Act is, of course, to make health insurance and premiums affordable by giving subsidies or credits to people who buy health insurance through health insurance exchanges, either at the state or at the federal level. And that was one of the elements that was challenged in the Supreme Court and recently upheld just this past summer. Lastly, ensuring that there is fair and reasonable access not only to health insurance but also to healthcare services is the other key component of this health reform being successful. Now, how is the Affordable Care Act designed to achieve these three goals? How do the three legs of the stool interact with each other? So here are the major components of the Affordable Care Act, and we're going to go through each one of these in detail so that you understand how all these elements work together to hopefully achieve the aims of the law, but also how comprehensive and sweeping the changes to the U.S. healthcare system have been as a result of the passage of this law. So the first thing we have is the individual mandate. The individual mandate says that all U.S. citizens and legal residents must have health insurance. They must have coverage under some health insurance policy. Now, if you are a young adult under the age of 26 and your parents have health insurance, you can remain on your parents' either group or individual health insurance plan. The reason why this provision was put in is that we know that many of the young invincibles, the young healthy individuals who maybe can't afford the cost of health insurance when they're working in their very first job and making relatively low incomes, that those people are often likely not to be covered by insurance. And so by extending the age and requiring all health insurance companies that have ACA approved policies to allow for the coverage of children up to the age of 26, it helps cover in a more reliable way that younger population. Now, of course, there are exceptions to the individual mandate. Some people will not buy health insurance either through an exchange or have access to it through their group insurance, through their employer. Those exceptions include people who live in extreme poverty, religious objectors, American Indians, because in the United States there is a separate health system that is set up for Native Americans called the Indian Health Service. So they are not required to buy insurance because they have guaranteed access to their own hospitals and providers through that system. Prisoners are not required to buy health insurance because they have access to health care via their institutions where they are incarcerated. And we also have the transient uninsured. So if you are uninsured for less than 3 months, you're not going to be subject to any penalties or fines. What we also see is an exception to the individual mandate is that no one is required to spend more than 8% of their annual income on health insurance premiums. So if someone can document that they would not be able to buy health insurance without exceeding that 8% cap, you would not be subject to penalties or fines. Of course, starting 2 years ago, what we saw is that anyone who does not buy health insurance by that start date pays a penalty on their taxes, and the penalties were graded. So the first year, if in 2014 you did not have health insurance, the penalty was $95. Next year, in 2016, what we're going to see is that the penalty has increased to $695, which is a very large incentive to motivate people to want to buy health insurance. What we see here also is that people always wonder how many people are impacted by the individual mandate. And the answer is, in the scheme of people who are eligible to buy private insurance, the non-Medicare or non-elderly population, out of those 275 million individuals, only about 32 million are really going to be impacted by the individual mandate and be required to buy health insurance, because there are a wide range of exemptions, as we just mentioned, as well as all the people who are already covered by employers, by Medicaid, or by Medicare. And so actually the number of people that we anticipate will be purchasing insurance through an exchange at the state or federal level is only about 32 million, so a very small piece of that pie. The employer mandate. There were also obligations put on large employers as a result of the Affordable Care Act. The first one was that employers with 50 or more full-time employees have to offer a health insurance policy to their employees and cover some portion of the premium. Now, for small businesses, that means employers with 49 or fewer employees, they are not required by law to provide health insurance to their employees. Now, what the requirements are and the obligations in terms of what kind of health insurance plan employers are required to offer is governed by the law. What it basically says is that you have to have any ACA compliant or approved plan, which we'll talk about the provisions of those approved plans in a few minutes. Employers that are very large, more than 200 employees, have to automatically enroll workers into the plans that they offer, so you're sort of added by default. Now, of course, you can always elect as an individual to not take your employer's coverage, whether you're automatically enrolled or whether it's offered to you. So it doesn't force you to use your employer's insurance. You can always still go out to the private sector market, to the health insurance exchanges if you have one in your state, or at the federal level and buy your own health insurance, even if you are employed. So, Medicaid expansion. Now remember, Medicaid is the federal and state combined program that provides health insurance for the poor and disabled. There are financial requirements for you to be eligible for Medicaid. So if you are at or near the federal poverty level, you will be eligible for Medicaid. The Affordable Care Act allowed for states to expand the criteria by which people could be eligible to participate in the Medicaid program. And the reason for that is that there was a very clear acknowledgement that many people who, not just who are living at the federal poverty level or below, but even people who are living around the federal poverty level limits, that those people are unlikely to be able to afford the health insurance premiums that the market currently bears. And so the Supreme Court ruled in favor of this provision of the Affordable Care Act and allowed for Medicaid programs to be expanded in those states as an option. Each state has chosen how they've implemented their Medicaid expansion and whether or not they're doing that. And of course, what the federal government has done through the Affordable Care Act is to create incentives for states to be able to engage in these expansions. So they provided some funds that will allow for states to expand. So here you see a map of the current status of whether or not states have expanded their Medicaid programs. So what we see in the states in orange is that these are places where you have to use healthcare.gov or a federal partnership or marketplace because they did not expand their Medicaid programs. So we see most programs in the South, as well as through the central part of the United States, elected not to expand their Medicaid programs. Now, there are 13 states who elected to expand Medicaid and also opted not to operate their own state-based exchange. So they did the first part of this, which is Medicaid expansion, but do not run their own health insurance marketplace in the state. The blue states are the dark blue states are the states that both have a state-run and operated health insurance marketplace and that expanded their Medicaid programs, and that's approximately 16 states, including Connecticut. Now, there are some states, at least one, Idaho, that elected to establish a state marketplace but did not expand Medicaid at this time. This is as of 2015. And that's the state of Idaho. So what we see is a lot of mixing and matching of the various provisions of the Affordable Care Act. It wasn't a one-size-fits-all implementation of this bill. States were given a lot of discretion in terms of what they do, particularly in how they run their Medicaid programs, because ultimately it's a state-based program with federal supporting dollars. What we see in terms of Medicaid eligibility is that if you're not eligible for Medicare, the federal insurance program for the elderly or the chronically ill, then you may be eligible for Medicaid if you have an income of 138 of the federal poverty level or less. Now, the official federal standard, and this is a little confusing, is actually 133% of federal poverty level, but 5% of all income is disregarded as negligible. So basically, if you're at 138 or below of the federal poverty level, you are eligible for Medicaid. So, of course, the question is, how much money is that? At what level are people being eligible for Medicaid in the United States? The federal poverty level for a single person today in 2015 living in the continental 48 United States is $11,770 for a single person. So if you make less than that amount, you are below the federal poverty level, which means that you would be eligible, depending on which state you are in, either for the Medicaid program, or you may not be eligible for anything if you live in a state without Medicaid expansion. What we see also is that the federal poverty level is adjusted for the number of people in your family as well. And so a family of 4, for example, making $24,250 a year would also be considered living at the federal poverty level. And so what you see here is that depending on whether you live in a state that expanded Medicaid or did not expand Medicaid, you would be eligible for certain kinds of programs or to buy certain kinds of policies. So if you live in a state like Connecticut that expanded its Medicaid program, their Medicaid program was expanded to include 138% of the federal poverty level, so that you would have eligibility through the Medicaid program at that level. Between 138% and 400%, you are eligible to purchase health insurance through a health insurance exchange and have access to a subsidy that will cover part of your health insurance premium. Now, if you live in a state without Medicaid expansion, what you see is that there are many fewer people who are eligible for the Medicaid program, because anybody making more than $11,770 a year, for example, if you live in Texas, has to go out and buy their health insurance through the federal health insurance exchange. So that's how that piece works. What we see here, and this is some data from the Kaiser Family Foundation in their health policy group, what we see is that there's a lot of varying eligibility by state in terms of what's required. So what we see is for childless adults, the standard is 138%. But for pregnant women to be eligible for Medicaid in both expansion states and not expansion states, it's actually around 200%. So basically, if you are a pregnant woman who is single, you could be making up to $22,000 and $23,000 in some a year and still be eligible for Medicaid because of the standards across these states. What we see is also that there is a differential for children in terms of the eligibility levels. So even parents or families that make significantly more than the poverty level still have coverage in those Medicaid expansion states, because again, there is an effort on the part of these states to include as many people as possible. Now, how does this work? As I mentioned, Medicaid is a state-administered program that is supported by federal grants and federal dollars. So the federal government created this giant pool of money that then they give to states to support their Medicaid expansion programs. And the goal here is to have 21.3 million new Medicaid enrollees by 2022. The question is, well, why did the Affordable Care Act put in a provision to expand the Medicaid program? And the hope really is that ultimately states will be able to bring in more people to hopefully improve their health outcomes. Hopefully the Medicaid programs will become more efficient and more effective, and so there will ultimately be savings to the state in terms of improving people's health and health outcomes, ultimately spending less in the long term on the Medicaid population, and also getting providers generating revenue through the state Medicaid programs that ultimately will impact economically all of the states and improve the overall financial health of states. Now, this was the assumption, and this was the hope, that it would have this impact of increasing the number of people who have access to health insurance, improve the state Medicaid programs, and ultimately improve state economies. Whether or not that comes to pass remains to be seen. Now, health insurance credits and subsidies. Now, this was, again, as I mentioned, something that was challenged in the Supreme Court because the question was, can the federal government provide a rebate, provide a credit to individuals in their respective states for buying health insurance through these health insurance exchanges, either at the federal level or at the state level? So people who have limited incomes, who are between 138% of the federal poverty level and 400% of the federal poverty level, are eligible for premium credits and subsidies. Again, only U.S. citizens and legal residents can receive these funds, and the federal government doesn't give these credits to an employer just because they're buying health insurance for their employees. This is only for individuals buying insurance in the private health insurance market. What we see is that the credits are based on a person's adjusted gross income that they report on their tax form and what level of federal poverty level they fall into. You get these rebates on your tax return in the following year. So if you bought a health insurance policy in 2014 and carry that insurance policy, when you file your 2014 tax return in the spring of 2015, because you file it the next year, you then are eligible to get that rebate. So all that out-of-pocket cost you actually have to spend during the 2014 calendar year, but then early in 2015 you get a portion of those premiums back. What we see also is some regulation from the Affordable Care Act that required that all plans being sold in the United States through approved state or federal health insurance exchanges had to contain these 10 minimum essential benefits. It's a way of ensuring that health insurance plans are all going to fairly cover all the same conditions for all Americans, and that there won't be these plans that don't cover certain kinds of key essential services like preventive care or like emergency care. So these minimum essential benefits ensure that the basics are being covered by all legally sold health insurance plans in the United States. It also requires that plans cover 60% at least of those estimated costs of benefits, right? So the cost sharing is capped for individuals at 40%. So, health insurance exchanges. A health insurance exchange is really just a store. It's a place where you can go to buy something. It is in every state something that primarily exists virtually online. It's like the Amazon of health insurance. States who chose to set up these exchanges received support from the federal government to do so. 38 states have elected to set up their own exchanges. So Connecticut is one of those states. You can go to accesshealthct.com and you can go on to the website and you can put in your personal information, how much money you make per year, how old you are, and it will generate an estimate of what you'll pay per year and also what your subsidy will be, how much money you will get back. Now, if you happen to live in a state that doesn't have a health insurance exchange set up for that specific state, you can buy your health insurance through the federally operated exchange, which is called healthcare.gov. So you either buy your insurance at the state level or through the federal program. How these exchanges work is basically you have to not be eligible for any other coverage through your employer, through a spouse or a significant other. You have to not have other coverage and to be able to purchase those. And these exchanges have only been operating for a couple of years. They've only been in existence since 2014. And so that's one of the challenges, is that there were many hiccups in the rollout of many of these exchanges. What is expected is that approximately 27 million Americans will enroll in new health insurance plans by 2017. And the current projections and estimates that the federal government set out for the first 2 years actually have been met and have been exceeded. So we're sort of on track in terms of what the federal government was hoping in terms of these health insurance exchanges. Now, again, we've already talked about the premium and cost sharing subsidies that are available. So we've talked about the premiums. So if you make between 100 to 140% of the federal poverty level, you are eligible to receive money back on your tax return. There also is support for the poorest individuals at 100% to 250% of the federal poverty level to get money back for your out-of-pocket costs. Now, many of these plans are high deductible plans where you may have an initial $2,000 to $4,000 that you pay out of pocket. So if you're at the lowest level of poverty and you don't live in a state where you can be covered by Medicaid, you would be eligible to get some of these cost sharing subsidies and get some of those out-of-pocket costs back as well. So basically, there's a range of options, right? So there are states that just have their own exchange and they manage everything themselves internally. There also are exchanges where there's a state-federal partnership, where the state operates and governs a lot of things, but the federal government also assists and plays a role in terms of the administration of that exchange. And then there's the federal exchange, healthcare.gov. Now, in terms of the requirements of private insurance sold through these exchanges, there also are very strict regulations and guidelines about the kinds of benefits that can be included in these plans, as well as the amount of cost sharing or out-of-pocket expense that individuals can expect to have. There also are allowed to be different tiers or levels of health insurance coverage. So there are 4 tiers: bronze, silver, gold, and platinum. The bronze plans are the plans that are usually the cheapest in terms of monthly premium, but there's a larger percentage of cost sharing in terms of out-of-pocket costs. As you go up the scale, what you see is that the platinum plans have the highest premiums, but maybe the lowest cost sharing in terms of out-of-pocket costs, in terms of co-pays and in terms of deductibles. So there's allowed to be some variation so that people can pay whatever monthly costs they can support based on what they know about their existing health expenditures. They can make a choice that it works for their budget and their financial situation. What we also see, however, is that there are some differences between these bronze, silver, gold, and platinum plans in terms of the network coverage. So you have to look very carefully to make sure that a bronze plan actually includes the same set of providers as a platinum plan, because that's not always the case. That's one of the ways that the health insurance companies are able to make these plans at different price points, is because sometimes the networks or the number of participating physicians in the bronze health insurance plans is much smaller than those at the platinum level. What we also see is that all of these plans have a cap on the maximum amount of out-of-pocket costs that an individual will pay per year. So, for example, if you're a 28-year-old woman making less than $22,000 a year, you cannot spend more than $1,900 per year out of pocket, right? So there's a percentage. And that's that 8% number. You cannot spend more than 8% of your annual income on out-of-pocket costs. Then that's when you're eligible for rebates and other kinds of things. So what we see is that there were also a wide range of other changes to private insurance. It wasn't just the tiers. It wasn't just in terms of taking away the pre-existing condition requirement. There were lots of things that were being done to the private health insurance industry. So here's a very detailed list, but probably the most important one is eliminating the pre-existing condition exclusion. And this is the thing that people often know the most about. So it used to be the case in the private health insurance market that when you would apply for private, individual, non-group, non-employer-based insurance, what would happen is that you would have to fill out a health questionnaire. You would have to disclose all the conditions and all the treatments that you'd ever received. And on the basis of those disclosures, health insurance companies could either say they would exclude you from being treated and providing coverage for those pre-existing conditions, or they could simply just offer you a higher rate for your insurance on the basis of those pre-existing conditions and the likelihood that they're going to have to spend money on those conditions like diabetes or low back pain. Or they could simply reject you outright on the basis of your health status. So those three things used to be true. The Affordable Care Act eliminated all three of those things from the health insurance industry. Now people cannot be denied on the basis of their health status. They cannot be charged higher premiums on the basis of their health status. So it's a much more fair system. So going back to Gruber's three-legged stool, that change itself in private insurance really made a significant impact in the fair access part of the three-legged stool. What we also see is that there were significant changes in terms of the lifetime expenditures that people could be expected to make. So lifetime limits on health insurance policies were eliminated. It used to be that many policies would say that they will spend up to $1 million per year, in your lifetime on you. And your coverage can't be taken away just because you meet that cap. So that's another important piece, is that once people are insured, they can't have it be taken away just because they have a lot of healthcare expenditure. It also limited the amount that you could have in a high deductible health plan. So a high deductible health plan is a health plan that basically says everything that you spend in a calendar year before X amount of dollars is your personal responsibility. After that, let's say $10,000, if that's your deductible, then the health insurance will pick up 100% of the cost. Those high deductible health plans, $5,000, $10,000, $15,000 deductibles, are no longer legally sold in the United States. Instead, the deductible cap is limited to $2,000 a year for individuals and $4,000 for families per year. So you cannot buy through a federal or state-sponsored health insurance exchange a plan that has a deductible that's higher than that. So that's another really important piece of ensuring the affordability of the healthcare system and of health insurance in the United States. So we've focused on sort of the consumer experience and the affordability of healthcare up till now. Now we're looking at the other side, the cost side. So there were a wide range of innovations and projects and experiments that were being done to try to, as we say in the healthcare industry, bend the cost curve. Now, what does that mean? What we have seen in the United States year over year for the last 30 years is that the trend line for healthcare expenditures has been consistently going up like this on a steep incline. Year over year, we spend a greater and greater percentage of GDP on health in this country. What analysts have been trying to get the U.S. government to be able to do is to start to get that curve to turn the other way, to begin to spend less overall. Now, the challenge is, of course, that at the same time when we're trying to bend the cost curve, we also are covering more Americans in the United States. So our per capita spending, we might be able to get to go down, but our overall global health budget in the United States is obviously going to significantly expand as more and more people are on the Medicaid programs, are signing up for health insurance through the private market. And so that's another piece of this that you should remember, is that overall our government and our society is going to spend more and more on healthcare as more and more people have ready access to the system. So there were many experiments and programs that were put in place. Some of them have been more successful than others, but basically the big categories were to reduce fraud and waste and abuse in the Medicaid and Medicare programs, to reduce administrative costs so that there would be not all this administrative bloat that we see in the healthcare system, to try to make the Medicaid system more efficient, and then also try to get Medicare payments to be done not on a volume basis, but on the basis of quality and on the basis of health outcomes. And so that's where we see a lot of the changes in reimbursement happening in the United States, is all because of the Affordable Care Act. There also were some significant changes to policy in terms of prevention and wellness. Many of you may not know that, in fact, it is the Affordable Care Act that is responsible for the fact that all chain and fast food restaurants around the country are going to be required to put the nutritional content in the food on the menu when you go to those restaurants. So that's a big piece of sort of promoting the idea of healthy eating and wellness in the United States, and that's something the Affordable Care Act did. They also put together a wide range of strategies and incentives to encourage healthy behaviors, to support more advanced, more robust smoking cessation programs, to establish employer wellness programs, a wide range of projects that were designed, again, to get us to have better health outcomes and a healthier population overall. Now, as if that weren't enough, there are some other major provisions of the Affordable Care Act that are worth mentioning. At the same time, when we're trying to reduce costs per capita, to reduce expenditures in the healthcare system, and ensure people have access, we're also simultaneously trying to improve quality. And so there's been a wide range of Medicare innovation projects that have been done in the last 5 years to really develop and evaluate this new bundled payment system. This was a direct result of the Affordable Care Act. To really look more closely at home health care and to really move hospitals to a value-based purchasing program and to really get hospitals into doing much more robust quality improvement and quality measurement of their performance as opposed to using the volume-based system that had happened before. What we also see is a much greater emphasis on primary care and coordination and collaboration. This is where we see the movement toward having accountable care organizations coming out of the Affordable Care Act, also having much more transparency in the U.S. healthcare system, requiring financial disclosures of conflict of interest between doctors and pharmacists and pharmaceutical companies, for example. That's been a big initiative that's happened in the last 5 years. Also beginning to make some inroads in the area of health disparities was a big priority in the Affordable Care Act. Now, one of the areas that the Affordable Care Act attempted to deal with is the industry of long-term care. But unfortunately, the CLASS Act, which was a component of the Affordable Care Act to develop a separate voluntary health insurance program for assisted living and long-term care, ultimately, in the implementation of the Affordable Care Act, the Department of Health and Human Services decided to scuttle that because it was just too much to do. It was on top of trying to implement healthcare.gov and to get all of these health insurance reforms in the private health insurance program up and operating. Making changes also to this new voluntary health insurance program just wasn't possible, so it was gutted. But many other kinds of improvements to how long-term care is funded have been being operated in the states as well as at the federal level to try to improve the funding and ultimately the outcomes of long-term care as well. We also see that there have been significant investments in our health system overall. We know that we have a shortage of primary care providers, and so there's been a large emphasis on increasing the number of graduate medical education training positions, particularly in primary care and rural health, to ensure that we're actually going to have enough healthcare providers to treat the people who are going to be accessing the healthcare system in the coming decades. And so providing ways of incentivizing people to go into primary care and public health has been a big aspect of this. Also providing significant funding for community health centers and public health initiatives to really make those preventative services and primary care services much more robust than they had been in the past. We also saw that there were major improvements that were proposed to the Medicare program. Again, this is the program for the elderly, providing additional support to beneficiaries of the Medicare program who have Part D coverage. Now, Part D is the pharmaceutical benefit coverage part of the Medicare program. So in the Medicare program, for people who elect to buy Part D, there's this really weird cost-sharing thing that happens. And this cost-sharing mechanism that they ultimately were able to approve when they reformed Medicare in 2003, the Medicare Part D provision, as part of a political compromise, they had to create what we call the donut hole. So what they said is that ultimately to cover all prescription drugs for all seniors was going to be radically too expensive and ultimately bankrupt our government. So what they said was, we'll approve a small portion of Medicare Part D coverage for seniors up front with no cost sharing required. And then there will be a portion in the middle that is required for coverage policyholders to pay themselves out of pocket. And then anything above approximately $2,500 then will be fully covered for seniors after that. So there was this gap in the middle where there was a significant amount of cost sharing for seniors. What they did to help improve the program is to provide some support for beneficiaries who are in the donut hole and to try to shrink the amount of coinsurance in the donut hole down from 100% that you had to pay out of pocket in the donut hole down to just 25% in 2020. So that would be a significant benefit for seniors if the Medicare Part D cost sharing could go down by 75%. Again, there were lots of other changes in terms of trying to provide incentives to primary care physicians and others who are treating Medicare patients in underserved areas, and capping the amount of cost sharing overall in the sort of private sector Medicare Advantage plans, the plans that you can purchase from people like AARP and Aetna and others. So these Medicare plans that don't cover just the hospital care, but the Part B coverage, that is coverage that has now very strict rules on cost sharing for seniors as well. So you may be wondering, this all sounds great. This sounds like a really fascinating set of proposals and reforms, but from a consumer perspective, how does it really work? So the point here is what you see is that it's not just a health insurance website that you can go to. There are actual physical offices that Access Health CT and others have where you can go, you can sign up using pen and paper, but the process is the same whether you're buying through whether you're buying through a state or federal health insurance exchange. You're going to fill out your application. There's going to be a single application that determines your eligibility, whether you're first eligible for Medicaid or CHIP, or whether you need to go to a private exchange. Then they will verify your eligibility based on the information that the government has about you, your previous salary level from your previous tax returns, your social security number. All of that then determines whether you are eligible for coverage and at what level and with what subsidy, right? So all of this is done in real time to allow people to make an informed decision about buying their health insurance. Now, of course, the implementation of this was not done without challenges, and in fact, it was pretty catastrophic failure for healthcare.gov when everyone went online on October 1st of 2013 to buy health insurance for the very first time, and the website didn't work and it crashed and data wasn't securely stored, and there were literally hundreds of problems with the implementation of the federal exchange. And so this has not been easy. But again, the scale of this project is enormous. All of these people from around the country who are looking to buy health insurance through a federal exchange was a significant information technology feat that they were eventually able to fix it. The picture on the right actually shows that had the Supreme Court not ruled in favor of the constitutionality of these marketplace subsidies, all the people living in these states where they have to buy insurance through healthcare.gov could have lost those subsidies, which ultimately would have made it unaffordable. So here we see an example of someone who is an unmarried graduate student who makes $20,000 a year. They don't have eligibility because they're over the age of 26. They are looking to buy health insurance, and so what they are going to do is go to Access Health CT and try to buy health insurance through the private market. If you're a full-time grad student and don't have a full-time job, then that is your only option, is to try to buy health insurance through the private market on Access Health CT. And if you haven't been to that website, I strongly encourage you to go to that website and take a look around. Now, the politics and public opinion of this, of course, is huge. What we saw is that this bill has not just been challenged in the court. It was very difficult to get it passed through Congress in the first place. There was not a general consensus amongst Americans that having the Affordable Care Act is what the country needed to do. Now, back when it was passed in 2010, 3 years later, they did a survey and they said that almost half of Americans didn't know that the Affordable Care Act was still in effect. So that's something that is obviously very troubling, that people don't really understand that the Affordable Care Act is there and to help them with their health care costs. At the 5-year anniversary of the law, what we saw is actually relatively little change in terms of public opinion over time. Looking at whether people were favorable or unfavorable, what we see here is that about 43% of people view it unfavorably. Now, when the act was first passed and this poll was first done, there were more people who were favorable than not favorable, but it hasn't been a huge change. And what we see is that basically the country is very evenly split between people who are in favor of it, not in favor of it, and then people who just don't know or don't care. And so it's a very partisan, very political divide that we see in the United States of the people who like and don't like this law. What we also see is when we look at the views of the public amongst people who have either the unfavorable or favorable views, what you see is the reasons why they have an unfavorable or favorable opinion. So the people who like the Affordable Care Act like the fact that more people, which may include themselves or others that they know, are going to have more reliable access to health care, right? It's all about getting people fair access, that part of the stool. On the other side, we see the people who are unfavorable. They really fall into two categories. One is concern about the cost and the sort of federal government requiring them to make this expense. And then we see people who are kind of philosophically opposed to the individual mandate. They don't like being required to have to buy health insurance. And you also see here kind of this general dislike of the government. And so I think that that's something that some of these unfavorables are just ideological, they're political. Others are more concerns about how will it be implemented and what will it do. Either it will have certain financial or cost implications, or that it will allow people to have more regular access to the healthcare system. So some are very practical, operational issues, but others are more philosophical. When we look at what people think about who to trust in all of this political debate and turmoil, what we see is that individuals really trust their healthcare providers the most, including pharmacists, and then sort of government agencies. But when you ask them, well, who have you heard about the Affordable Care Act from in the last 30 days? It's primarily the news media, not a source that they particularly trust, or friends and family, who may not be the most informed about these issues. And so I think that's another struggle is for our healthcare system is how to get providers to help be the source of information and to be advocates for ensuring that people have adequate coverage and ensuring people have a regular source of primary health care and those kinds of things. There has been steady opposition to the Affordable Care Act, as we've already mentioned, over time. But ultimately now the next challenge, the next opportunity for it to be overturned really will be in the 2016 election. But when you ask people, even though there are all these people who are opposed to the Affordable Care Act, how much impact do you really think it's going to have on you? The largest proportion of Americans say it's not going to really make much difference at all. And that percentage is consistent with about the number of people who are covered under employer-based insurance. If you already have health insurance, the Affordable Care Act isn't really going to impact you much at all. And if you look at the data, what you see is that a larger percentage of people think that they will be worse off than they think they will be improved. And so I think it's interesting how people have these sort of negative perceptions of the Affordable Care Act, even though we know a very small percentage of Americans overall are likely to be impacted at all. So where does this leave us? What does this suggest for the future of healthcare in America? What we see is that ultimately, since the health insurance exchange opened and since these requirements have been put in place, the Affordable Care Act has resulted in about 5% of the uninsured population going down in the first year of open enrollment. There are approximately 8 to 9 million people who are newly insured between Medicaid expansion and private insurance enrollments. What we see of the people who enrolled through the exchanges at the state and federal level, almost 60% of those were previously uninsured, right? So these are not people who already had health insurance from another source or had an employer-based plan, but then decided to buy through the exchange. 60% of these people had never had health insurance before. And that's a really significant measure of how in fact, the Act is doing what it was designed to do, which was ensure that people have more ready access to the healthcare system. Now, what are the attitudes of these newly insured Americans? Overall, what the research shows is that there's a high level of satisfaction in certain areas. The shopping experience, the number of plans available, the amount of choice that consumers were able to make. Many were unhappy with the fact, though, that there is a high level still, even though there's a cap of $2,000 or $4,000 for these high deductible health plans. Many were still dissatisfied with the amount of either deductible cost or cost sharing. And so what people say is that cost was the primary factor in choosing a plan. How much out-of-pocket cost were they going to have, or how much would their monthly premium be? Interestingly, though, when you ask these newly insured Americans how many of them have really benefited from their new insurance plan, only about 4 in 10 say that they have. So if you actually go to this link here, you'll actually see a wide range of statistics from a huge national survey that looks at the attitudes of newly insured Americans, which really shows a lot of these statistics as well as others that really show that overall people are still very concerned and are very sensitive to costs when they're choosing and using their health insurance plans, and that many people really aren't seeing a major benefit. Now, of course, the concern of that is if ultimately when the option comes around again to renew or not, if people don't feel like that they're really benefiting from their insurance plan, they may elect not to enroll and simply take the penalty on their taxes instead. And that will remain unknown until we go through a few more cycles of open enrollment and we can measure how many newly insured remained insured versus dropped off the rolls. I think another big challenge for the future of the U.S. healthcare system and the implementation of the Affordable Care Act going forward is health insurance literacy. Now that we have millions of more Americans who are covered under the Medicaid program and the private health insurance, do they actually know how to use health insurance? What statistics show is that, in fact, many people overestimate what they know about their health insurance policies. Only 3 out of 4 people felt like that they do know how to use it. There's a sense of kind of overconfidence. But when you ask them specific questions about what your out-of-pocket costs are, what's a copay, what's a deductible, tell me the difference between copay and coinsurance, only 1 in 5 people could answer those questions correctly. And so what we see is that there's a sense of kind of perceived competence and knowledge about the healthcare system, but when you actually test people's knowledge, it's very poor, which means they're maybe unlikely to use the healthcare system effectively. So without some increased health insurance literacy and consumer support and patient navigation for the healthcare system, I think we're going to see that the ultimate benefits of that insurance increase and enrollment may be minimized. So what we really see is that we need a combination in the United States of financial literacy and health literacy to have what they call sort of health insurance literacy. And I think that's something that we need to move toward. It would have been great if that had been built into the Affordable Care Act. It really wasn't. There were some very small amounts of money that were put in place for health insurance navigators to help people to sign up, but then that money went away. And so now there isn't sufficient resource or support for people to become knowledgeable about all these things, to be able to communicate with others and to be their own advocate in the healthcare system. So looking forward to what's coming for the Affordable Care Act. Every fall, the health insurance exchanges will open. There will be an open enrollment period. Any states that haven't expanded their Medicaid programs, they still have the option to do so at any time. They can opt in and out of the expansion whenever they want. So whether more states will expand once it's sort of been determined that the Medicaid expansion programs are working remains to be seen. The future of the children's health insurance program, which is sort of a subpart of the Medicaid program, is unclear because even though the Affordable Care Act allows for the CHIP program to exist until 2019, there's no funding authorized to give to the states from the federal government for the CHIP program as of next year. So whether or not Congress will reauthorize those funds will determine whether or not the CHIP program will be around for states that have it. It remains to be seen sort of how the primary care system will be strengthened and how care coordination efforts will take place. And so it is expected that these health system reforms and the payment reforms that are driving all these health system changes are going to be effective, but that still remains to be seen over time as well. Of course, we know that there's significant room for improvement. This chart shows the number of potential people who were eligible to enroll for private health insurance, who were uninsured, to sign up in the federal states where you could buy it through the federal exchange. So these are not the states where there's a private exchange set up. And what we see is that there are a lot of light blue and medium light blue areas, particularly in the central part of the country, where only between maybe 25 to 40% of Americans who are eligible to sign up for health insurance through healthcare.gov actually did. There are some places where the coverage and people who are eligible is highly saturated. States like Maine, parts of Wisconsin, parts of Michigan have very high levels of people signing up through healthcare.gov. But there are many parts of the country where people are still not electing to buy health insurance. Ultimately, what we'll see coming down the pipeline in 2016 is that the estimate is that the reduction of the number of uninsured in the United States will decrease by about 11%. We'll see the Medicaid population, because of the expansion programs, will have increased significantly, and we've already seen some of that. That private non-group insurance, the insurance policies that you buy through the exchanges, that population will obviously continue to increase. And what we'll see is that the employer-sponsored health insurance market will shrink a little bit. And so what we are expecting to see is these sort of dramatic improvements over what we know would have happened if the status quo had remained the same and the Affordable Care Act had not existed. So to close, the Affordable Care Act has had a very difficult 5 years since it has been signed into law. It has been challenged in the courts. It has faced major implementation barriers, and it's still being challenged as part of the 2016 presidential election. So depending on who is our new president next year, that will really determine whether the Affordable Care Act remains as it is currently configured. The Affordable Care Act has dramatically changed the health insurance industry, the hospital industry. It has raised consumer awareness about these issues and has enrolled many, many more people in health insurance. And I think that's probably its greatest success. Significant work remains to actually improve healthcare quality and to really begin to bend the cost curve and to deal with many of the dysfunctions we see in the U.S. healthcare system. But ultimately, that's what this act was designed to do. And over time, hopefully many of its provisions will be successful so that our healthcare system is no longer the outlier in the world in terms of not providing access to our citizens and to having the most expensive, lowest quality system amongst our industrial peers. And so really the goal of this law was to make the United States a place that really is no longer the laughingstock of the rest of the industrial world in terms of our healthcare system. And whether that will happen still remains to be seen.